This is a quick review of Chapter 10, 12, and 13 for Test 3. Complications after birth. So make sure you know hypovolemic shock. And make sure you know the difference between late and early postpartum hemorrhage. You should know what DVT symptoms are and postpartum infections, fever, obviously, think endometritis. Know what subinvolution of the uterus is and what it's called. Know a little bit about the different mood disorders. So basically, baby blues are pretty normal. Nothing is ever normal. It's still a deviation from the norm. But baby blues are not too serious. Postpartum depression is a little bit more serious. And then postpartum psychosis, that's the one where they're going to be on medication for sure. They're going to be admitted to the hospital, and that one's they're at risk for injuring themselves and the infant. So shock. So you've reviewed this in MedSurg, so just make sure you know hypovolemic shock, really know that one. So early hemorrhage is within 24 hours. Late hemorrhage can be after 24 hours up to 6 weeks. And tachycardia, and then low blood pressure, pale, cool, clammy skin, change in mental status, and decreased urinary output. So if somebody has 20 mLs per hour, then you know that that's not enough. So under 90 over under 60 is too low, and a little trick is if it's at least 90, you usually can feel a pulse. If you can't feel a pulse, it's most likely under 90. So you don't always need equipment to assess your patient. So the first sign, tachycardia. I'm going to see if I can play this video, but I don't know if it'll work. So it's pretty fast. So what happens? Heart rate goes up, blood pressure goes down, body's trying to compensate. So the first thing you want to do is stop the blood loss. Also, IV fluids. So if they don't have an IV access, you need to give them IV access. You may need to replace blood products or volume, oxygen, and always an indwelling catheter. This is really important to know. Anytime somebody is in critical condition or they need to be closely monitored, then they need a catheter so you can accurately measure their urinary output. We know it's 30. So looking at hypovolemic, we already know this. Decreased cardiac output and increased systolic vascular resistance. But you don't need to know that. But decreased cardiac output just means that the heart, what the heart is supposed to be doing, it's not doing. Frequent vital signs, oxygen, look for the lochia, assess that, look for firm fundus. So if the fundus is firm, then it's doing what it's supposed to be. So if there's still a little bit of bleeding, then it's most likely just from a laceration. If the fundus is boggy or soft and there's bleeding, then that's from the uterus. Anemia, loss of red blood cells, dizziness, lightheaded. It may be because of low iron. And if somebody has anemia just from pregnancy, they're not going to bounce back as soon as they have the baby. You know, those red blood cells take about 120 days to turn over. So they really need to be on iron supplements for about 12 weeks. So heart rate of over 100, you want to report that. The early postpartum hemorrhage, that's within the first 24 hours. So they could have uterine atony, which is subinvolution. The uterus is not shrinking down to its pre-pregnancy size at the rate it should be. They could have lacerations, and they could have hematomas, which you can see in the picture. Floppy, flaccid uterus. Oh, I just want to go back. Causes uterine overdistension, so that's why you want to assess their urinary output, and also retained placental fragments. So that could lead to endometritis, uterine lining infection postpartum later on. So if there's a deviation to one side of the fundus, assess the bladder. A full bladder can slow down involution. But you always want to do fundal massage first, whether it's deviated or not. And if the fundal massage does not make that uterus firm up and it is deviated, then empty their bladder. But sometimes you can just empty their bladder. If they haven't voided for a few hours, then you know that's the problem. But for NCLEX and test purposes, the first action is always to massage to firmness. Characteristics of uterine atony. It's difficult to fill. It's very difficult to fill a smushy uterus versus a firm uterus. Imagine that uterus just like it was in labor. You should be able to fill that through the subcutaneous tissue. There might be increase in lochia or discharge and large clots. The lacerations, just a little bit different. Sometimes they need to have those repairs, depending on what degree that tear is. If you remember back when we were looking at first, second, third, fourth degree tears. So it may just be something that just heals on its own, or they may have had suturing, so that's another wound that you need to assess. And hematomas, pretty common, but they can be very painful. So late postpartum hemorrhage. This is most likely retained products of conception or placental fragments in their subinvolution. So this is going to happen possibly after they leave the hospital. They're going to have a reverse order of lochia, so they may have been having pink or white discharge, and then all of a sudden it's bright red. That's not normal. Subinvolution is just when the uterus is not shrinking down at the rate it should be. So it should be about 1 centimeter per day. So when you're looking at fundal height, you're measuring, it might be 2 finger breadths above the umbilicus, it might be at the umbilicus, it might be 2 fingers below the umbilicus. But if you document that it's at the umbilicus or below the umbilicus, and then the next shift documents that it's above, then you know that that's the wrong direction. So first action is to massage the uterus. Make sure you know that. So some interventions are massaging the fundus, putting the infant to breast because that's going to release oxytocin in the brain, and then also giving medications of oxytocin or Pitocin, which is going to make that uterus cramp down and squeeze off all those blood vessels, and that's going to stop the bleeding. So thromboembolic disorders. So pulmonary embolisms are definitely something you need to look out for, but they're going to occur after a deep vein thrombosis. So we're going to focus on deep vein thrombosis. If a woman tells you that she has bilateral calf pain and there's no redness, good pulses, the pain is not along a vessel, probably nothing. What you really want to look for is one-sided redness, inflammation. That's alarming. One-sided, it means that there's a specific reason. If it's both sides, it could just be that they're fatigued. And Never do the Homan sign. So for PE, you're going to see trouble breathing, dyspnea, coughing. They may have chest pain. Women who are, anyone that has a PE, they usually have this like very strong apprehension feeling, like this feeling of impending doom, like they're very terrified that their body is telling them something's wrong. It's very scary. So this education is for anyone who is at risk for DVT or PE. So if someone has AFib, if they've recently had surgery, if they've been immobilized for a long period of time, if they've been pregnancy. Pregnancy is a hypercoagulable state up until the end of the 6 weeks postpartum period. So, and this is true for anybody too. This is good for students who are sitting around a lot. Do not cross your legs. Do not sit or be in a position where your knees are bent for more than 2 hours. That the pressure on your popliteal space, it cuts off your circulation. Early ambulation. Early ambulation, elevate head of bed, turn, cough, deep breathe. Those are like just nursing pearls that you should know. Range of motion exercises. They can have stockings sometimes. Lots of fluids. When you're stuck on a plane or a car, move your little toes every hour or so. It's better to stop the car every 2 hours and get out and do something, stretch, drink water, than it is to sit in a car for long periods of time or a plane. Oh, if they need to, they may get warfarin for 6 weeks. And this is going to minimize the risk of an embolism, having it move up to their lungs. So they could have prolonged bleeding from little tiny injuries, nosebleeds, unexplained bruising. They want to use a soft bristle toothbrush, which people should use anyway. They need to follow up with labs. Make sure you know. For heparin, it's PTT, and for Coumadin, it's PT. And in cardiovascular, you should be learning about INR. If you haven't yet, I am going to make PowerPoint or YouTube videos for your med-surg class. So it's really important to kind of understand the basics of INR. So I'll explain that to you. So now the antidote. The antidote for Coumadin is vitamin K. So infection, that 100.4, you know that is infection. And puerperal is just postpartum. Hand hygiene. Hand hygiene. I don't know how many times you can probably have that drilled into your head. You want to prevent infections. So mastitis. Redness and heat to the breast. It could be one breast or both. Tenderness. It's going to be painful. Edema. Breast is going to feel heavy. There may be purulent or pus drainage. Maybe not. Fever, chills, and other systemic signs of infection. So systemic means your body. So if you have a localized infection, you may have like a little redness and swelling and may irritate you. But if you have fever and chills, then that means that your whole body's kind of fighting it. And there definitely may be an abscess. So treatment. There may be antibiotics, mild analgesics. Continue to breastfeed with an unaffected side. They can pump and discard milk from the affected side to prevent engorgement and stasis of milk, which can worsen the infection. Heat promotes blood flow to the area. So this is important to know for women who do not want to breastfeed, because not all women want to breastfeed. They should avoid like hot showers, because that's going to slow down the milk drying up. Want to massage the area. Lots of fluids, wear a supportive bra, and provide emotional support. This is really upsetting to women. I'm so sad I have to stop breastfeeding my baby. Yeah, it's not necessary that you discontinue breastfeeding. You can continue. So this one is an abscess, and you're definitely going to get antibiotics. mood disorders. So the baby blues are common. Postpartum depression, a little bit more serious, and then be empathetic, be a good listener, and then psychosis is the worst possibility. And make sure you know that not all women are leaving the hospital to go to a home. So fever, think infection. First sign of hemorrhage is tachycardia. Think over 100 for pregnant women, postpartum women. Involution is the return to pre-pregnancy size of the uterus. Subinvolution is slower than expected or failure of the uterus to return to its pre-pregnancy condition. Uterine atony, floppy, soft, boggy uterus. It's difficult to feel, and there may be large blood clots. Firm fundus with bleeding is probably vaginal laceration. Soft, boggy uterus indicates postpartum hemorrhage. Hematoma, just a little collection of blood under the skin. Subinvolution, initial nursing action or intervention is to massage the fundus. Subinvolution with deviation to one side, massage, and then assess the bladder, empty the bladder. Medications for treatment are oxytocin, which is Pitocin. Return of bright red bleeding after it's changed to pink or white indicates postpartum hemorrhage. That's not good. Report that. Have the patient report that. Hypercoagulable stage, which means that you coagulate your blood. You have thick blood. You're going to clot easier. That can last up to 6 weeks postpartum. And vascular complications are DVT or pulmonary embolism. Unilateral, one-sided redness and swelling, DVT, and treatment warfarin, possibly heparin for 6 weeks. And the warfarin antidote is vitamin K, 100.4 fever. Make sure you use good hand hygiene. Mastitis is an infection of the breast. Only stop breastfeeding that side if there's an abscess. You know the difference between the different types of psychological issues. And I'm just going to read some stuff that's not on the slide. I think we've covered everything. Okay, I'm going to go on to the next chapter. Chapter 12. This is the term newborn. So they're not premature, they're not post-term. So respirations, remember the blood does not need to circulate through the lungs. There's no oxygen carbon dioxide exchange when the baby is in utero. So that first breath opens up those alveoli. And there's independent air exchange. The baby's breathing on its own now. These are, you do not need to know this stuff. So some things about newborns. Their metabolism is impaired, so they have an immune digestive system. Their liver is not quite grown up yet. So medications, foods, the enzymes that they need to digest foods are not quite there yet. The kidney's ability to concentrate urine and maintain fluid balance is limited due to the increase of the glomerular flow and limited renal tubular reabsorption. So the glomerulus is the functioning part of the kidney that filters everything. So if that's not functioning, then they could have dehydration or they could have fluid volume overload. Things just aren't working right. And then their neurological functions are primitive. Make sure you know the variations and deviations from normal and what should be reported. Some reflexes that are primitive. You don't need to know these for the test, but these are kind of interesting. These you need to know. Moro rooting, tonic neck, and dancing. You need to know these. So startle reflex. Oh, you startled me. Their hands go out. And then the rooting reflex is for helping them feed. And the tonic neck or the fencing. They look like they're trying to fence somebody with that little sword and thing. And then the dancing and or stepping reflex. It looks like they're trying to walk, but they're not. So make sure you know the difference between caput and cephalohematoma. Cephalohematoma does not cross the suture line. It's only on one side. Caput, think of a baseball cap. It's going to cover both sides of the head. Fontanelles are soft spots that protect the head during delivery and allow further brain growth. So the caput covers the whole head and it's normal, like a baseball cap, whole head. Cephalohematoma is not a good sign and it's only on one side. It does not cross these suture lines. It's just that one side. So you don't need to know the average for head and chest circumference, but you do need to know that they're measured in centimeters, not inches. The circumference of the head should be less than 2 meters greater than that of the chest. So if you have a head circumference of, I'm just going to throw out a weird number, 30, and you have a chest circumference of 25, that's more than 2, so that's abnormal. So the head should be about 2 inches larger, but not more than 2 inches. Hearing is present at birth. Hearing test. Tears are absent until about 1 to 3 months. Keep a safe, calm, quiet environment. 15 to 20 hours of sleep per day. Pain pathways developed by 24 weeks gestation. So there's just some pain assessment tools. The more common ones in blue. Cries, FLAC, newborn to 7 years. NIPS is for newborn neonates, so 0 to 28 days, newborn. And Wong-Baker is for 3 years and up, not for infants. Condition responses are reflexes that are learned over time. There's behavior assessment scales, respiratory system. So once the umbilical cord is clamped and cut, lungs take on the function of breathing, O2 and carbon dioxide exchange. First breath expands the lungs. Full expansion does not occur for several days. So the most critical time is that first hour. A newborn should be positioned on their back or side to help maintain a patent airway. Bulb suctioning. Make sure you know the 5 components of the APGAR. It's at 1 and 5 minutes. Know the signs of respiratory distress and know vital signs for a newborn. You need to know vital signs for a newborn. Foramen ovale and the ductus arteriosus close after birth. Normally, if they don't, that's not a normal situation. Infants cannot regulate temperature. They don't have sweat glands that are functioning. So temperature. So temperature is rectal or axillary. Heart rate is always apical for 1 minute. Nasal flaring or chest retractions are not normal. Make sure you know their normal vital signs range. So 99.8 is a fever. Temperature is decreased. So you want to make sure the temperature. So there's heat loss through convection, conduction, radiation, evaporation. So you want to use kangaroo care, keep them warm, and babies don't need a bath right away. And you're going to wash the head after everything else. So they're uncoordinated. They are not trying to walk. They're just flopping around, reacting, twitching their muscles. So children always develop from head to foot and from center of the body to the outside of the body. And that's not just in infants, that's just how development works. The average newborn length. So this is what you need to know. Weight loss. 5 to 10% of their weight loss is normal. Greater than 10% is concerning. So to calculate, let's use 3,400 as an example. So if the infant weighs 3,400 grams and you multiply that by 1.05, you get 170. So if you subtract 170 from 3,400, that's 3,230. So that's 5%. So 3,230 is 5%. And if you take that same 3,400 and you multiply that by 1.1, that will give you 340. If you subtract 340 from 3,400, which is 10%, that's 3,060 grams. So you know that that's the range that they should weigh after birth. So once again, to do 5%, you do their weight times 1.05, and that number you get, you subtract from their birth weight. And then you can do the birth weight times 1.1 and subtract that amount from their birth weight, and that's 10%. So that their weight should fall within those two numbers. You don't need to know the average length and weight. So kidneys are not developed. So they don't have as much blood flow. Their ability to handle water load is reduced. They have a hard time reabsorbing important substances and concentrating urine. So they can become dehydrated. They can have electrolyte imbalance. So you're looking for roughly 6 to 8 wet diapers a day, or 6 to 10 wet diapers a day, somewhere in that number. So between 6 and 10, that's what you're looking for. So skin system. So they have lots of little lanugo, little fine hair. So if they're preemies, they have more. If they're term, they have less. And then if they're post-term, they might not have any of that lanugo. And the same with that vernix, that's that white, thick coating that they have. So let's talk about jaundice. Physiological jaundice is not such a bad thing. They may have yellow skin or sclera, and it's caused by rapid destruction of excessive red blood cells. So a little sclera, little skin. Now, if they have too much bilirubin, they're at risk for brain damage, which is called kernicterus. So too much bilirubin is putting them at risk for brain damage. So if they have yellow skin, yellow eyes, they could end up with brain damage. So you want to assess that and report that. So if it appears in the first day, it's not normal, and it needs to be reported. So pathological, the bad jaundice, happens in the first day. Physiologic jaundice happens after the first day. So I would know these labs. It's going to be roughly page 294. I'm not sure what page it is in the newer book, but I would know these basic values. And then we went over this in class, but hemoglobin and hematocrit. So they're both measuring red blood cells. And it's roughly a 1-to-3 ratio. That's normal. If it's not anywhere near a 1-to-3 ratio, there's probably something going on. So you have the plasma here, the liquid part. So the amount of oxygen carrying capacity is the hemoglobin. So that's a number that you can't see on the tube. That's oxygen capacity. Hemoglobin is protein that is on red blood cells. Then you have the red blood cells. So this is the hematocrit is looking at the percentage, and that's the bigger number. So you can see them. So in this one, it's saying it's 41%. So you can see that's not quite half. So when you think of hematocrit, think of a percentage, and you can visualize it. So hemoglobin and hematocrit. So if you see 11 over 33, then you know that the 11 is the hemoglobin and the 33 is the hematocrit. And that's how they write it for H and H. Sometimes they'll just write it, the numbers over each other, like a percentage, like a fraction like that. GI system normally functions right after birth. The meconium is the first stool, and it's usually sticky green, black tar, and it could be more than just the first stool. And that's usually gone in about 8 to 24 hours. And when you think of normal consistency and color, think of mustard. Mustard. So day 2, that should not be meconium anymore. And it's going to be a little bit different whether they're breastfeeding or bottle feeding, and the amount of stool is going to be increased if they're breastfeeding. So vitamin D, 400 international units a day, and then iron supplements at 6 months. Full-time infants have iron stores from their mom that is depleted by 4 to 6 months of age. So that's why it's important for them to start getting iron. So prevent infections. Remember, they have an immune system that is not fully matured yet. So they can't fight off those infections. And most infections come from the umbilical stump site. So good hygiene, keep it clean. You don't need to do any kind of special soaps or anything. You just need to keep it clean. Immunoglobulins. So this is really not on your test, this part right here, but IgG means it's gone. You had it in the past or you have an immunity. IgM means you're miserable now. You have an active infection. And antigen is something that goes into your body, immunizations or contracted disease. And antibodies are what your body makes to fight the disease. If exposed, antibodies are what they say they test with titers. So they're trying to see if your body converted to antibodies or not. Not everybody converts after vaccines. Some people, their immune system just does not convert those antibodies. So if somebody has, for hepatitis, hepatitis B surface antigen means that they had a previous disease or they're immune. And hepatitis surface antibody, if you ever see this one, it means that you have immunity to hepatitis B. So babies have passive immunity from their mother. It's around 3 months, 4 months. And this is why some vaccines are not given until greater than 12 months, because they don't have a strong enough immune system, they would not be able to convert the antibodies themselves. And those are the MMR live viruses. So if an infant does have an IgM, which is miserable now, that means that they have a serious infection. Infants and young children, when they get a fever, they're at a very high risk for having a seizure. That does not occur in adults. So when a kid has a fever, you need to treat it as a very serious thing until you know it's not. So just assume it's the worst possible scenario. IgA, know this one. IgA is the immunoglobulin that infants get from breast milk, and it provides some resistance to respiratory and GI infection, and those effects can be throughout childhood. Before 1 month, infants are at the greatest risk for these infections. So this is a real good benefit of breastfeeding if mother can. Discharge planning and parent teaching. There's so much. Basic infant care, safety measures, immunizations, return appointments, proper use of car seat, and where to go to get their car seat inspected for insulation. And also, they don't recommend used car seats because you just don't know if it's been in an accident or what's going on with it. It's better to just it's better to get a new one or get one from somebody you trust, but I wouldn't recommend buying a used one. And signs and symptoms of problems and who to contact. So if the mother is having an infection or if the infant, so you're really doing patient teaching for 2 different patients. So home care, and we're going to move on to chapter 13. This is preterm and postterm. So preterm birth is the cause of more deaths during the first year of life than any other single factor. Postterm is 42 plus. Ballard score, you don't need to know that. Level of maturation. So for maturation, there was something I wanted you to know. Gestational age. Make sure you know the definition of gestational age. So there's small for gestational age and there's large for gestational age also. And under 2,500 grams, 5.5 pounds, and large for gestational age is greater than 4,000 grams or 8.8 pounds. This is a macrosomic baby. Normal and macrosomic. So causes of preterm birth, multiples. Mother has an illness, gestational hypertension, diabetes, something wrong with the placenta. So preterm infant, they have transparent, loose skin. You can see their veins. They don't have that sub-Q fat. They have lots of lanugo and vernix. The soles of the feet have very few creases. They'll have more creases as the gestational age increases, so they don't have too many creases. And things are a little bit smaller. Their abdomen is more protruding. So a little thin skin, lots of lanugo. You can kind of see their vessels, and their skin's very transparent. They have inadequate respiratory function. So surfactant is starting to form at around 24, 25 weeks, but it is not sufficient until about 34 weeks. So even though it's they're starting to make surfactant, it's not enough for another 10 weeks. So inadequate respiratory function. The air sacs enlarge. They're closer to capillaries in the lungs. Failure of this phenomenon leads to many deaths. So this is a respiratory depression. I'm going to see if, oh, I'm going to go back. I want to see if I can get that video to play. I don't know if it will. Oh, I think that video is not available anymore. Respiratory distress syndrome, RDS. Immature lungs, not enough surfactant. So begins to form at 24 weeks. Sorry, begins to form at 24 weeks. By 34 weeks, it should be normal. So remember, 24 weeks the surfactant starts, and 34 weeks it should be sufficient. A little long pathophysiology if you want to look at it. Normal and collapsed lung. So you see the dark, this is the lung spaces. And you see the outline of the heart here. So this is a little point of maximum impulse. See, it's like right along that sternal border. Now when somebody has heart failure, the heart will tend to shift this way. So make sure you know respiratory abnormalities in an infant. So normal respiratory rate, 30 to 60. So 60 or higher is tachypnea. Grunt-like sounds, nasal flaring, cyanosis, intercostal sternal retractions. Not good. So apnea occurs as the condition worsens. So it's actually a late sign. Very sad. They're going to have that central cyanosis all over. So treatment is going to be steroids. If they're not born yet, and I know that they're going to be born early, they can give them the betamethasone. They're going to get 2 injections of that in the mom. And preterm infants, they can get surfactant administered through an endotracheal tube at birth. And this will usually show improvement in about 3 days or 72 hours. So there's the betamethasone. It's got a little endotracheal tube there. Surfactant. Surfactant production can be altered if there's cold stress, so you want to keep them warm. Low oxygen, poor tissue perfusion. Remember, cluster their care, conserve energy. Apnea is loss of breathing for 20 seconds or longer. Bradycardia, heart rate under 100. And they may have cyanosis. So neonatal hypoxia. So if they have under 92%, it's not adequate oxygenation at the cellular level. Sepsis. It's a generalized infection in the bloodstream. Low temperature because they do not have a mature immune system yet. They may be irritable, tired, poor feeding. They may have respiratory distress. And the liver is immature, so you can't make antibodies. Everything is just not working. So treatment of sepsis is going to be IV antimicrobials. So when they administer, they're going to administer IV antibiotics based on per kilogram, and they're going to have 2 nurses verify that dose. You always have 2 nurses verify pediatric doses, and it's always weight-based by kilograms. Very strict hand hygiene. Poor control, body temperature. They have no thermal regulation, and this is for any infant, but post-term even more. They don't have any of that brown fat. They've used it all up. They don't have thermal regulation. It's immature. And they have a very high metabolism, so they're prone to low blood sugar levels and can result in cold stress, and then cold stress can lead to other problems. So high metabolism will lead to below glucose in post terms. So cold stress, decreased skin temperature, increased respiratory rates with periods of apnea, so that 20 seconds or longer, slow heart rate under 100, modeling of the skin that looks like that marble, and then they're lethargic. They're not as active as they should be. So you can use a radiant or warmer heater, radiant warmer or incubator, and also kangaroo care. So hypoglycemia. In a term infant, are you kidding me? There's a fire alarm going. Under 40 for term, 30 for up till 12. Abdominal distension if there's stools in the abdomen. Look at this. Know this. Skin to skin kangaroo.